All right, good afternoon, everyone. Welcome back. Hope you all enjoyed your lunch and had a minute to rest or relax. We're now going to take a look at mental health services and what we can do as a purchaser to help improve outcomes. Dr. Sun, our chief from the Clinical Programs and Appeals section, is back with us to lead the discussion, along with a panel of experts in the field. So with that, Dr. Sun, I'll turn it over to you.
Thank you. We're happy to have with us today three very enthusiastic and knowledgeable folks in the area of mental health. We'll begin with Dr. Susan Ettner from UCLA, talking about federal mental health parity laws. Aria Darley from the American Psychiatric Association Foundation will speak on 4 ways to improve behavioral health care for purchasers and employers. And finally, Rebecca Friant from the SEIU 775 Benefits Group in Washington State will talk about barriers to quality mental health treatment and potential solutions. And then we'll open it up for questions and answers. So I'll begin by passing the microphone to my left to Dr. Ettner.
Thank you very much, Richard. Okay, so I'm going to start first with a little bit of background. Historically, insurance coverage for treatment of mental health and substance use disorders was worse than for medical conditions. This may have been motivated by stigma or possibly due to fear among health plans that patients with behavioral health conditions were more prone to adverse selection or moral hazard. But regardless of the motivation, this disparity had real implications for access to care. So, for example, one study found that 2/3 of primary care providers reported difficulty getting outpatient mental health care for their patients. That was twice as much difficulty as the same PCPs reported for other medical services. And the vast majority of those PCPs said that the major reason for this access problem was inadequate insurance coverage. It's also important to point out that improving generosity of behavioral health benefits could have spillover effects onto the primary care or other medical sector. For example, if you make behavioral health benefits more generous, then that paves the way for specialty providers to be managing the care of the sickest patients rather than the primary care providers having to do that. It's also conceivable that there would be cost offsets in terms of reductions in the use of emergency department and hospitalizations if you improve care of behavioral health conditions. So as a result of these inequities in insurance coverage, states began passing insurance parity laws starting in the 1970s. Parity just means equality of coverage for behavioral health and medical care. And one example is California State Assembly Bill 88, which said that plans had to cover diagnosis and medically necessary treatment of certain mental conditions under the same, quote, terms and conditions as they did for medical conditions. So despite the passage of many state parity laws, advocates generally viewed these laws as inadequate for 2 main reasons. One is that the laws varied quite a bit across states in terms of exemptions, in terms of which benefits and conditions were required to be at parity. And then another equally compelling reason is that ERISA exempts self-insured plans from state mandates. And as it's become more and more common for plans to self-insure, this means that fewer and fewer plans are actually subject to the state parity laws. So as a result, there was a strong push to pass a federal parity law. This led to the first federal parity law, which was the Mental Health Parity Act of 1996. This law stated that large group plans offering mental health benefits could not have lower annual and lifetime spending limits on mental health than on medical services. SUD was not included here. But this did have an unintended consequence. Since they only specified that annual and lifetime spending limits had to be at parity, a study by the General Accounting Office found that most of the newly compliant employers ended up changing plans to be more restrictive in other ways. For example, cost sharing became less generous, and some plans imposed limits on the number of outpatient visits or inpatient days that would be covered following the passage of this Parity Act. A different example of unintended consequences of parity came with the parity that was implemented by the Federal Employees Health Benefits Program. So what happened there is that after they implemented a much more comprehensive parity bill, Basically, a lot of the plans ended up switching to a carve-out model of care, and carve-outs generally tended to have more direct utilization management than carve-in plans. And so again, it was like the balloon analogy where you're saying, okay, you have to have parity in all these ways, but because they didn't cover these direct utilization management techniques, the plans ended up becoming less generous in that way. So the lessons learned from these prior examples led to an effort to have a federal parity bill that specified parity in all benefit design features, including the quantitative treatment limits, which refers to these visit and day limits, and what we call the non-quantitative treatment limits, or NQTLs, which refer to these other sorts of utilization management techniques, such as pre-authorization or medical necessity review. So all of these efforts led to a much stronger federal parity bill, the Mental Health Parity and Addiction Equity Act of 2008. This was effective starting October 2009 as plans renewed. And this said that employers offering mental health and/or SUD coverage could not apply financial requirements or treatment limits that were more restrictive than the predominant requirements and limits that apply to substantially all medical and surgical benefits. The bill also prohibited separate accumulation of deductibles and out-of-pocket maximums. However, it did not require coverage at all or specify particular diagnoses that had to be covered. So, for example, it was conceivable that a health plan could choose to just entirely drop behavioral health care coverage. There were also some small group and cost exemptions. The interim final rule for this legislation turned out to be very important, not only because it added legal compliance requirements, but it also added parity in the non-quantitative treatment limits. So again, these were things like pre-authorization, medical necessity review, reimbursement levels, the long list of different things that were covered. So this made the original piece of legislation much stronger and more comprehensive. And then there was a final rule that basically retained the NQTL provisions and clarified interactions with the Affordable Care Act, and also stated that parity rules would apply broadly to more populations than what had originally been conceived. So Bush et al. Had the first published evaluation of this parity legislation, and they found only modest effects, but they were only able to look at the first year post-parity, and they also focused strictly on SUD treatment. So at UCLA, we wanted to do a very comprehensive evaluation looking both at mental health and SUD, and also including all the various aspects of benefit design and utilization and costs of specialty behavioral health care. So we used 2008 through 13 administrative databases from a large national managed behavioral health organization. We used regression methods to compare benefit design, utilization, and costs of behavioral health care in the pre-transition and post-parity periods. In terms of results, first, very importantly, we did not find any evidence that employers were dropping behavioral health coverage altogether. It was true, however, that some employer groups chose to switch out of the carve-out model back into a carve-in model, and this was because there was a much greater administrative burden for compliance that fell onto the carve-outs rather than the carve-ins. When we looked at financial requirements such as co-payments and co-insurance, we found only modest effects, in some cases mixed effects. I think that was because many of the plans were already at parity beforehand. But we did find that the parity law improved insurance benefits, and it did that in several ways. First of all, the vast majority of plans prior to parity had imposed visit or day limits. So for example, we'll only cover up to a maximum of 20 outpatient visits or 30 inpatient days. Post-parity, those limits literally just vanished. This was a very striking finding. Another finding in terms of the NQTLs is that many of the pre-authorization requirements became less stringent post-parity. This was, we could only look at this among the carve-out plans, but the NQTLs definitely also looked like they were being relaxed. And then the other finding for the carve-outs is that deductibles were now newly combined. So prior to parity, the carve-in plans had already been combining medical and behavioral health deductibles. Virtually all of them did that. Virtually none of the carve-out plans did that. And post-parity, they developed methods for the carve-out vendors to work with the independent medical vendors to combine deductibles. When we looked at utilization and costs, we didn't find very large effects, but we did find stronger effects among Carve-in enrollees. We found that there were significant increases in the use of individual psychotherapy visits. We also found that there were some increases in plan and total spending driven primarily by out-of-network use. As an example, in a representative post-parity month from our sample, we looked at July 2012, and when we predicted the estimated per enrollee total spending in that month, we projected that it would have been $6.90 without the parity legislation, but it was $8.40 with the parity legislation. So it did look like use went up among the Carve-ins. I should note that the parity effects that we found for utilization and costs were also stronger for children and young adults and were stronger for patients with substance use disorders, who tended to be among our most expensive patients in the sample. But we did not see the same thing for those with severe mental illness. Among carve-out enrollees, there was a less consistent impact on utilization costs, probably because the carve-out enrollees were using more than the carve-in enrollees to begin with. However, we did find some evidence that patient financial protections improved. So there was cost shifting from patients onto plans, which was a good thing for the consumers. I realize that the graph is very busy and confusing, but the basic takeaway point that I want to make here is that prior to parity, the patient out-of-pocket costs were increasing and were projected to continue increasing for the next few years. And when parity came in, basically there was a downward shift in the intercept, so patient out-of-pocket costs went down and then basically stabilized. I know it looks like there's a bit of a downward slope, but that wasn't significant. So basically there was a jump down in patient out-of-pocket cost, and that remained. Okay, so a couple of things. Why weren't effects larger? First of all, we looked at very comprehensively, but there were some things that we couldn't look at, and so therefore it's conceivable that there was non-compliance in measures that we didn't look at. For example, we were not able to look at how the definition of medical necessity was applied for behavioral health versus medical care. There's also the opposite issue, which is that many of the plans were already compliant with benefit design features such as co-payments or co-insurance rates. So there may not have been much room for them to improve. Limited networks, limited provider supply is a major concern or constraint to utilization that would need to be looked at further. It's also true that because we have commercially insured patients, some of them may have been relatively healthy and wealthy, so that they might be less responsive to reductions in cost sharing than, say, a sicker or a less wealthy population would have been. Perceived stigma is always a big barrier, and there's also poor information among providers and patients in terms of the parity law and what people's benefits are. So that may have led people to not fully exploiting their more generous benefits under parity. Okay, so in conclusion, the federal parity law did improve behavioral health benefits, especially for people who were high utilizers to begin with. However, parity laws alone are probably insufficient for addressing the access barriers. In an era where medical benefits are shrinking and there are known shortages of primary care providers, we may want an absolute standard for ensuring access to care rather than a relative standard. So, for example, under parity, you just have to match what's going on the medical side. So if there's inadequate access on the medical side, then you may well get inadequate access on the behavioral health side. So this begs the question of how generous ought benefits to be, and how many providers do we need to ensure access to needed behavioral health care. And finally, we need to really address non-financial barriers in conjunction with the financial barriers. And I know my colleagues are going to be speaking about some of these issues in a minute, but there are strong geographic barriers, provider shortages in rural and underserved areas. There's often a lack of integration with medical care, and my personal favorite that I think we need to address is the lack of diversity in the behavioral health care workforce. For example, only 6% of psychologists come from diverse backgrounds, And we already know that racial concordance and gender concordance in medical care is an issue, and that, to my mind, is probably an even bigger concern for behavioral health care. So we need to address diversity issues. And finally, we need interventions to identify unmet needs for behavioral health services, to educate patients, and to address perceived stigma, especially among older and underserved minority populations. Thank you.
All right, so there are many ways to address behavioral health care, many ways to improve it, but today I'm going to share 4 ways. And before I get started, I just want to acknowledge the incredible amount of influence and power you have as change agents for behavioral health care. And I do realize that CalPERS makes health care decisions for nearly 1.5 million lives. And for that reason, I just want to say thank you so much for creating this platform and allowing us to have a conversation, a discussion about behavioral health. And thank you, Dr. Sun, for allowing me to be a part of this discussion. So before I share those 4 ways, I do want to describe some of the growing concerns around behavioral health and access to care. I want to describe some of the concerns with the traditional care model and the way we treat patients right now. Well, not me, I don't treat patients, but the way most primary care providers treat patients, and then also describe some of the treatment approaches that are more effective. So one of the growing concerns, not a concern, but we know that mental health conditions are very common. 1 in 5 experiences a mental health condition in a given year. So that's 43.8 million adults directly experiencing a mental health condition. And out of that 43.8 million adults, 41% are experiencing any kind or getting any kind of care. So any kind of care could run the gamut of like going to a community health center or seeing someone who has maybe a certification in behavioral health and things like that. More formal care is more in a primary care setting. Specialty care would be seeing a psychologist or things like that. And then 12% are actually seeing a psychiatrist and getting proper medication for whatever condition they are experiencing. Other health concerns is that mental health disorders is the #1 cause for disability worldwide. And in the US, it is the top, well, out of 10 top reasons, it accounts for 4 of the reasons why people go out on disability. And those who experience a mental health condition, they live their lives 21 to 32% of their lives with disabilities. So that's up to 1/3 of their life that they're living with disability. And when you compare it to things like cancer, someone who is experiencing cancer, that is 24 times higher that they're living their life with that disability. Also, suicide, that's a big concern, especially given the attention it's getting, or it has gotten in the recent few months, especially with 2 high-profile celebrities dying by suicide. 1 suicide every 14 minutes, so possibly in the time that I'm speaking with you today, someone could die by suicide. And while there's no one reason why someone dies by suicide, we do know that some of the risk factors are attributed to mental health conditions like depression, bipolar disorder, schizophrenia, and also substance use disorders. So that's another concern, but then we also have health plan participation. Many behavioral health providers are not participating in network, and we have to ask the question as to why. I mean, there's several reasons as why, but a lot of the behavioral health care providers that we talk to just say they won't see anyone unless they're paying out of pocket. So that's a real concern. And then also there's a shortage of behavioral health specialists. Susan kind of touched on this a little bit, but the mean age even for a psychiatrist is 58 years old. So a lot of psychiatrists or a lot of physicians are choosing not to take that up as a specialty, and there are reasons for that as well. And then of course there's the rising healthcare costs. So with all of that kind of considered, some of those concerns, we have to look at how we are currently treating those who may be experiencing some kind of behavioral health condition. So currently, someone walks into their primary care office, their physician, and they say, maybe I'm experiencing, depression. I don't know what it is, but I no longer have interest in the things that I once enjoyed, or they're just, can't get out of bed, those sort of things. And the primary care physician will either give them an antidepressant, which is a whole nother story. I won't get into that. But most oftentimes they'll give them a referral, and then that person may or may not see that psychiatrist or follow through with their appointments. And really, only half of those who are referred actually follow through. So that's a significant concern right there. But then after they follow through, many times the average number of visits is only two visits, and sometimes that's just not enough to address some of the complexities associated with any mental health conditions. Also, there's a pervasive issue of stigma, and as I mentioned before, some of those concerns around behavioral health, that there are just not enough providers, and oftentimes when people do follow through, again, they're having to wait months sometimes before they actually see the psychiatrist. And that sometimes that really causes a lack of engagement, and that, you know, somebody just kind of sits on that condition and think that, okay, well, I'll just deal with it myself and it'll resolve itself. So with all of those things considered, I mean, I'll ask you the question. I mean, do we refer more patients to psychiatrists? Is that a good way to do it? Or do we, probably not, right? Do we somehow magically produce more psychiatrists? We can't do that either, right? So we have to look at more effective treatment approaches that will allow people to get the care that they need. So collaborative care is an effective treatment model. It's an integrated care model that has really shown great results for those who are in the model. And what happens is there is the same scenario, but instead of getting referred out, that patient is actually seeing a care manager. And usually the care manager, part of the prepared, proactive practice team, that care manager actually screens them for depression using a PHQ-9 or a GAD-7, maybe anxiety or something like that. And they go ahead and they get the prescriptions that they need if they actually screen positive. And then that primary care physician, also part of the proactive team, they're actually going to prescribe the medication, and if they have a more serious mental health condition, then of course they'll get referred to a psychiatrist. But part of that practice is also a consulting psychiatrist who is actually not going to see the patients in face-to-face, but what they do is they're looking at the caseload, looking at how the patient is being treated or how the patients are being treated, and then they're also making recommendations as to, because that's their specialty, they're making recommendations as to how that person is going to be treated and the best moves forward for treatment. And of course, let me just say this, that everything that's taking place is being held in a web-based registry. And so that also allows the care providers to establish baseline and also track progress along the way for the patients. So, understanding that there are some room for improvement, there are some things that we have to address as it relates to improving care, and there's so many different moving parts in this whole model. But one of the things that we've been able to do is we've been able to look at just all different aspects and really consider what the health plans are experiencing, looking at what the employers are experiencing, and then also the behavioral health care specialists, what they may be experiencing. And so through the collaboration of the APA Foundation, a group of rather large employers, a group of practicing psychiatrists, and also health plans, and also the National Alliance, we've been able to come together and come up with these recommendations. And so the 4 recommendations that we are saying that health plans and employers and CalPERS you should be involved in is expanding collaborative care, expanding that model, advancing measurement-based care, ensuring network adequacy and mental health parity, which Susan went into really great detail about, and then also expanding telepsychiatry. So there are a lot of different steps to each of these recommendations, but for the sake of time, I'm just going to highlight some of the key points. So with expanding collaborative care, we're saying pay for what works. Pay for what works, and collaborative care is a model that does work. And so part of paying for what works and making sure collaborative care is implemented is making sure that those CPT codes are turned on. We do know that that is available through Medicaid and Medicare, but we also want to make sure that employers know and health plans know that it's important that they are implementing those CPT codes. And then also there are modules that's available to providers through APA where you can access it free and just understand what the model is all about and adopting those CPT codes. So second, like as I said before, is advancing measurement-based care. And part of that is providing the incentive payments and minimizing administrative requirements to mental health and substance use providers who participate in network, and making sure that if there's a practice that's going to implement, collaborative care or any other model, that they're using those standardized measurement-based tools at regular intervals. And also, it's important for health plans to require that the health plans provide them with aggregate data from the results of those measurement-based tools. And then again, I don't have to go in too much into a lot of detail about parity, but I do want to talk about network adequacy, and that is an issue. That was one of the concerns that I mentioned a little bit earlier, that it's an issue when someone has to wait months before getting the care that they need. And a lot of times we know that health plans are struggling to bring people in network, but it's all about expanding the in-network providers and making sure that they have reimbursement rates that would allow them or be more compelled to participate in the health plans. Also, it's important that they keep the directories, the health plans keep the directories up to date, because a lot of times what happens is an employee or enrollee may call to schedule an appointment with a provider, and then they find out that they're no longer on the list. And that becomes a major barrier a lot of times when you're trying to get care. And so what we're also doing is encouraging employers to ask health plans about the differences in frequency of in-network and out-of-network care for mental health and substance use care. And then we're saying to employers to ask about the denial of care rates for mental health and substance use services compared to other medical services. And then we're also saying that there has to be a communication between everyone. So the goal is the same, that we improve the care for those who need the care, but we also have to make sure that we're on the same page. So employers should ask those questions. Health plans should also be willing to provide the information that employers need to make sure we improve. And let me just go back to mental health parity. So it's also, this is not to there's no mental health parity police. We were talking about this a little bit earlier, but there are state insurance commissioners who are investigating health plans to make sure that you are in compliance, or we're in compliance. So it's important, again, that everyone is working together to make sure that we resolve some of these issues. And really, again, it's about improving that network adequacy and making sure that people are getting the care that they need, because a lot of times if nobody is checking and there's no police, as we said before, it's still a matter of making sure that we see some of the gaps in care and that we can provide it before employers are fined or things like that. And finally, we want to expand telepsychiatry. So telepsychiatry is one of those ways we can remove barriers, especially if someone is busy. It's hard for them to get into the office to see a psychiatrist. It's shown very promising results in itself, just because a lot of patients are reporting satisfaction to services, and they're able to share that it is convenient for them. What we're saying to health plans is share a link to APA's telepsychiatry toolkit. And then we're also saying to employers to make sure that they share this information, that it's available to enrollees about telepsychiatry, and require the health plans make the training available to in-network providers. And so finally, I just want to say that, you guys are very powerful, very influential in terms of your role. And again, I want to empower you to really take that and know that this is not a one-day fit. It's not going to one-day fix. It's not going to be something that resolves itself, and it's not something that's going to be fixed overnight. But it is something that we want to work with you on, and we want to hear from you. We want to be that resource. We want to be that ally to where we all can work together, again, health plans, employers, providers, to make sure that patients are getting the care that they need, and we can reduce the way or the concerns that we have, and make sure that we change the things that currently exist in the behavioral health care system.
Hi, my name is, I'm going to point that down a little bit. My name is Rebecca Friant, and I'm the manager for health improvement programs at SEIU 775 Benefits Group. And so I'm going to be talking a little bit today about some of the ways that we've been trying to work as an organization around improving access to quality behavioral health care for our members. So just briefly, I wanted to give a short introduction to what SEIU 775 Benefits Group is, because I think it'll give some context for some of the work we've been doing. We're a Taft-Hartley trust, and we administer health training and retirement benefits to home care workers who are part of the SEIU 775 union in Washington State. So there are 50,000 approximately home care workers total who are enrolled in the union, and about 18,000 of those home care workers are actually enrolled in our health benefits package. And we've spent really the last 3 years really trying to understand how do we help people get better behavioral health care access in this population. So the way that we approach pretty much any problem that we're trying to resolve in our organization is we look at data from a lot of different angles to identify areas of opportunities. Within the Health Benefits Trust, we specifically look at things like claims data, customer service complaints. We have a member resource center that people can call, and so we log things in Salesforce and get a lot of data that way. And then we also use literature review, qualitative methods, service design approaches, and survey data. So we have an internal service design and survey department, and then we also hire consultants for some work as well to really get caregivers to come in and talk with us about their experiences with various parts of the healthcare process. Once we really have identified those areas of opportunity and have gotten some of the consumer voice about what they would like to see in terms of changes, we generally don't scale programs right away. We pilot solutions first, so we try to do them at a small scale, test for effectiveness, kind of see where all of the unexpected weird things that happened with that solution happened. And then when we find something that's pretty promising at that point, we scale the program. And a lot of my job is taking those pilots and getting them up to scale for either the 18,000 members on the plan or all 50,000 in the union. Just as some very brief context, and I know Aria actually mentioned a lot of this. So 20% of the population will have a mental health disorder in a year, but actually if you look over people's lifetimes, 50% of people at some point in their life will have a diagnosable mental health condition. So that really means that mental health conditions impact all of us. If we personally will not have one in our lifetime, we probably love somebody who has a mental health condition. So this really, does have an impact for every single person in this room. 60%, as mentioned before, of people with mental health conditions don't get any treatment at all in a given year. So it's more than half. And we actually have treatments that work. So there's a lot of great empirically based research on things that can help people feel better. But even that 40% of people who go on to get some kind of treatment, they walk into an office and see someone, they will generally not get enough mental health care to actually recover and have real symptom improvement. So we knew that sort of at a population level. We also wanted to do some internal survey work with our own population to see how home care workers were impacted with mental health conditions. And so we have had 3 really large survey efforts that we've done. The first one that I think was really exciting was an exposure to adverse childhood events survey that our health and safety team did. So this they took a semi-randomized sample of home care workers and actually gave them a validated assessment of adverse childhood events. Adverse childhood events are traumas that occur in childhood. There's a whole variety of them, and there is a very strong correlation between exposure to those kinds of events and poor mental health and physiological outcomes in adulthood. And the more events that you experience, the more likely you're to have those kinds of negative outcomes. What we found was that caregivers were actually 2 times more likely than members of the general population who had taken the survey previously to have experienced 4 or more adverse childhood events. And that 4 number is important because that's really in the research literature the threshold where you really start to have a very strong correlation with negative health outcomes. And so that obviously raised a lot of red flags for us as an organization that we potentially had a population we wanted to be paying a lot of attention to in this area. We also have an anonymous depression screener that people can take through a variety of different methods, and we've actually had over 12,000 screeners completed as of April 2018. And what we found was that of those 12,000 screeners, 1 in 5 respondents were reporting moderate to severe depression symptoms. So again, that sort of raised some red flags for us that we have a population we really need to be providing good services to. We also did an anxiety screening that was administered to a random sample of home care workers, and 50% had screening results suggestive of at least some distress caused by anxiety. 20% had a likely diagnosable disorder. So at this point, we knew we had a problem. So what did we do? First, we analyzed our claims and health plan partner data. So what we found was that mental health services in our health plans are generally very severely underutilized. So given the survey results we were getting from our general population, we would expect actually high levels of utilization, and actually significantly less than 1% of our members were initiating specialty behavioral health care per month, which was shocking to us. We also were getting reports from our health plan partners about how long people were waiting for an initial appointment. And the average wait time, which means that's not the longest wait time, is the average was 28 days to an initial appointment with a specialty provider, which we felt was way, way too long to wait for an appointment. Then we actually brought some home care workers in to talk to us about their experience of behavioral health care. So we did some focus groups around how people wanted to get communications from us about what behavioral health options were available. And a lot of people actually expressed a preference for asynchronous and text-based communication. So they didn't really want to call a number. A lot of them didn't want to necessarily go in to see an appointment in person, but they were open to getting a text message about these types of issues. There was also a ton of confusion about what resources were available. So we actually try to have a really rich health benefit for our population. People didn't know what they could access. Stigma was a huge issue that came up. And also people really requested a desire for peer community. That's something that we hear from home care workers. A lot of the time it can be a very isolating profession, and people wanted more of a community around these types of issues. We also ran a mental health navigator service. So this was actually a pilot that I was involved in, where I was the mental health navigator, and people basically called me. I had a phone number people could call me at for 2 months, and I helped them schedule appointments with their health plans. And so again, we actually almost had to close down the pilot before we introduced an asynchronous communication option because no one called the number. We made it very widely available. Nobody was interested in initially contacting me by phone. When we basically developed a form people could fill out saying, hey, could you call me back? We got a lot more interest in the service. Relationship building we found was really important in terms of getting people to schedule an appointment. So on average, it would take about 3 phone contacts with a person once they had requested for me to call them back before we actually got them to the point of appointment scheduling. So there are in addition to health plan access barriers, there are lots of internal barriers for people to getting these kinds of services. And then, of course, there were systems and network adequacy barriers. We also did some pretty extensive qualitative interviews with 12 home care workers. And what they told us is that their job is actually a primary stressor for them and one of the big reasons that they have mental health issues that come up for them. Also, again, expressed a lot of confusion about resources, a desire for peer community, and once again, that issue of stigma came up for us. So this really started to narrow us down in terms of what kinds of solutions we were ready to start looking at and testing for this population. So we tried a bunch of different things. First, this is a low-wage population, so we thought, well, maybe we can eliminate behavioral health copays and that will make a difference, and it made none at all. So, and part of that might be that people were just not aware that their copays had been eliminated. The healthcare system is so complicated, and that's such a small line item, I'm not sure that that really registered. We also have recently implemented a couple of other solutions. One is the Ginger.io app, which I will explain a little bit more, and it expands access to telepsychiatry and offers a text-based coaching platform as well for caregivers. And we also have implemented mindfulness courses, both in-person and digital courses that we offer continuing education credit actually for people to take those as well, and have gotten some really fantastic results. And I'll talk a little bit more about that program. We're also working on implementing and onboarding an EAP service. So I want to talk a little bit more about mindfulness courses in Ginger.io. These are some really exciting interventions that I think are really expanding behavioral health access for our group, and we are seeing some great results from. So why did we choose mindfulness courses? First, we kept hearing from home care workers that they were stressed and that work was stressful, but that they felt a lot of stigma about seeing providers. And so offering this as a training course and really we advertise it as this isn't just a way to help you, this is a way to be more impactful with your consumers and your clients, really reduces stigma and increases a lot more interest and enrollment in the program. And then the online and in-person offerings, we have a lot of people in rural areas. Online gets to those people, and the course actually creates a community, which is really nice. From our initial results, so we did a pilot study. Participants had significant reductions in anxiety and depressive symptoms. Online versions of the course actually had even higher engagement than in-person offerings. And 87% of participants said that they were still practicing mindfulness 3 months after the course, which was fantastic. We're currently working with the Center for Mindfulness at UMass Med Center to bring the program to scale and actually offer this to thousands of caregivers every year. The other initiative, which I've been very involved in personally, is the Ginger.io initiative. And so the reason why we chose Ginger.io, they're a startup based in San Francisco, is they actually offer a text-based wellness coach, which really addresses that desire for asynchronous communication. And so they offer an app. The member is assigned 3 coaches, each with an 8-hour shift, so you can have continuity of care, and you can expect a response from your coach in less than a minute, 24 hours a day. The coaches do not have licensure, but if somebody needs a higher level of care than a health coach, they can be transferred to a psychiatrist or a therapist via secure video chat, and generally the wait time is somewhere between 48 hours and 4 days for an initial appointment, and the coach can continue follow-up while people are waiting for their appointment. So what we find is that we've really improved our access and decreased wait times significantly, and once users get into that system, they are very, very satisfied with the service that they're receiving, and that we're getting pretty good clinical outcomes as well. So for us organizationally, the big challenges that we're thinking about is how do we keep communicating with caregivers about mental health benefits in a way that reduces stigma, optimizes engagement, and how do we scale things? So most solutions that are scalable have a digital component. How do we address digital literacy issues in the population so they can use those tools? I'm going to stop there because we're at time.
Well, I'd like to thank our 3 presenters, and now we have some time for discussion. I'd like to ask the first question myself. As you know, later today the board will hear about a strategic measure concerning how often it was easy for members to receive treatment or counseling for a personal or family problem. Do you think this is a good measure in the area of behavioral health, or are there other measures that you would suggest the CalPERS adopt?
Well, I would say that if it were up to me, I would definitely include more questions about behavioral health, but understanding that there's a limit to, you don't want to have too many questions. I will, that question that you mentioned, I think I kind of focus on that word problem. And when you have that word problem, it kind of deters people, even if they're, kind of analyzing things themselves, it deters them from really telling their story or sharing information, because automatically they're going to go into defense and say, I don't have a problem. So you may want to, my recommendation or my suggestion is maybe to even change that word to maybe, concern or condition. Maybe it'll allow people to open up and maybe share, even if it's something really small that they see, it could be something where they could get help for, or their family member.
I agree with a lot of what Aria just said. I think a lot of it is thinking about, is that question going to get actionable data that a program could get built off of? And so what I would think about is, if people say that it's not easy, was it not easy because there was stigma? Was it not easy because the wait times were too long, or there wasn't a provider in network? Or was it not easy because the services were not acceptable to the client? And so I think that that question is a start, but potentially doing some surveying with subsample groups or qualitative interviews could help kind of narrow that down a little bit to figure out which problem is being addressed. I think also, so we really appreciate getting the access times from our health plan partners. That really helped us understand where we were having some gaps in access, and claims analysis is another, I think, really important piece. So there are definitely algorithms out there in the literature where you can analyze claims data and figure out, are people getting adequate treatment once they get into treatment? And I think that's a really big component of this as well.
Thank you. Yeah, so I agree with what everybody's been saying. I think that question is a good start, and I recognize, again, the resources that you can't devote too many questions on your survey instrument to this. I guess if I had my druthers, I would like to see more screeners or more objective measures of mental health need on the survey, and then maybe pair that with some analysis of administrative data to look at what people actually get. This is for two reasons. One is because, again, they may think that they got treatment they needed or didn't get the treatment they needed, but it would be nice to look at what they actually did get. And second is because people aren't always the best judges of what they need. And I think it goes in both directions. I mean, we were just talking about people who say they don't need services when they in fact do, but there are people who need services less who get services. There was a very interesting study a number of years ago by a psychiatric epidemiologist named Ron Kessler, and he divided mental health diagnoses into 4 categories. He had severe, moderate, mild, and no diagnosable disorder. And he looked among each of those groups to see what fraction of the patients actually got some kind of behavioral health care. And he found that while only half of the people with the severe disorder, such as schizophrenia, actually got any care, but 6% of people who had no diagnosable disorder got some care. Now, this doesn't mean that they didn't need it in some sense or that they didn't benefit from it, but they did need it less than the people with severe disorders. And even though it was only 6%, but of course there's so many more people in a given year who don't have a diagnosable disorder than those who do have a diagnosable disorder, that this meant that a lot of the behavioral health care resources were really going towards people at the lower end of the spectrum, the people who didn't have diagnosable disorders or who had mild disorders, rather than those with moderate to severe. So again, I'm a little bit concerned about saying, did you have a problem? You know, there's a lot of worried well that may say, yes, I had a problem and I didn't get treatment, and then you may be missing people who really did have high needs who aren't, you know, acknowledging that or recognizing that.
Okay, thanks very much. And we'll open it up for board questions or discussion.
Thank you. Questions from the board? Ms. Hollinger.
Yeah, I was just curious on the technology side and what is it, the Ginger? Does that significantly reduce the cost of to administer behavioral health?
That's a really good question. I don't know that we've been working with Ginger.io long enough to go back through our claims data and figure that out. But I think where it does potentially reduce cost is for people who are in the mild range. Instead of having to go into your primary care doctor and then having the claim, right, we're paying a PM, and then they just have access 24 hours a day to that coach. And if that's enough, then we sort of have avoided cost for people going to a specialist.
So do they have to get pre-approval for that?
No,
No.
so as long as people work for a sense-based employer, so for somebody who participates in the health benefits trust, as long as they've worked 1 hour, they get an access code, they enter their last name and date of birth, and they are in the system.
Got it. Okay, thank you.
Can you model for us how that transaction or that interaction might work? So someone sends an email to, or a text to a provider, how does that work?
Sure.
What does it look like?
Yeah, so I've demoed the product, and actually what I can also do, we have a video for how it looks to download the app, and I'm happy to send it to Dr. Sun, and he can share as well. But the app takes about 3 minutes to download, so you go in the Google Play Store or the Apple Store, you enter in Ginger.io, you press install, it installs on your phone. For our group, they answer just a couple of questions. I think there are 3 intro questions. They're asked for their access code, their last name, and their birth date. And then they're in the app. So at that point, they swipe a screen, and the coach, there'll be a little photograph of their coach, and they basically type in, hi, or whatever it is that they want, and the coach will actually just start texting with them. So when I demoed with the app, my coach was Sam, and Sam asked me, what brought me to the app, and I said, well, I have a toddler and I no longer sleep. Can you help me with my sleep issues? And so Sam gave me different exercises, and he texted me mindfulness cards and breathing exercises that I could work on, and things like that. And he actually even texted me the next day to follow up during his shift. And I, at one point, I had a question. So he was Mondays through Fridays, 6 to 2, and I had a question at 4. So there was a different coach I ended up texting with, but she had access to all of his notes. And so she could look back and see what we had been working on and help me with follow-up exercises and things like that.
Well, that sounds great. I mean,
Yeah.
it sounds like really an add-on. Obviously it doesn't solve all of the mental health, address all of the mental health issues out there, but it certainly sounds like something that could be really worthwhile.
Yeah, we've been very excited to offer it to our members. So.
And have you found that there are particular clinical areas where this has been most useful? I mean, for example, postpartum, as you mentioned a postpartum issue, perhaps lack of sleep. I've been there. But are there particular areas where you think this app is most useful?
So where we get clinical outcomes measures is for depression. And so I would say this is they have a whole list of specializations where we really see that this is useful is for mild to moderate depression. Caregiver stress is great. They actually can do stuff around wellness coaching as well. So if people want accountability on a weight loss plan or exercise plan, they can help with those kinds of things. Communication issues is something that they work on as well. They have a pretty wide range of different topics that they can work on with customers.
Thank you. Any other, Ms. Taylor, did you have a question?
So I'm so fascinated with the app. So I looked it up. Is it the cat? What is it?
I don't.
That's
It's
the
a
only
G.
thing that
It's
comes
a
up
big
is
blue-
talking ginger.
Oh, no, that's not it.
Okay. Hey, that's why I asked. You put in ginger and that's what comes up.
The spelling is ginger, ginger.io, and it should be kind of like a aqua icon with a G in the middle is, I think, what comes up.
Not seeing it.
Oh, I can come by during the break and
Sure.
show it to you. Yep, I'm happy to do that.
So I was just curious. Then I had one other question. You talked about having, and welcome from an SEIU member.
Oh, thank you.
You talked about having intervention like on the phone work that you guys have, and those are not licensed people. And you started that, right? Like you started it and then,
So I did a mental health navigation service, so all I did was appointment scheduling.
okay,
So I
these
didn't
people are
provide-
actually coaches then.
Yes, these are wellness coaches.
Okay, wow. And they don't have any licenses, and this is for your own members?
Yes, yeah. So that they have kind of a variety of training, and Ginger.io offers a lot of training as well to their coaches, but they don't have any like therapy licensure per se. They usually have a pretty strong health background, and then the licensed providers are available via video chat.
And this is what SEIU provides, or is this somebody that you contract with?
We contract, the company Gendrio provides the providers, so
Okay.
they're one of our vendors.
Okay, great, thank you.
Go ahead, Mr. Miller.
Yeah, thank you very much. I really appreciate all the information. And one of the things I'm just curious about is, I can certainly see how this can help reduce the cost of providing and hopefully increase awareness and access. But I also think, from my perspective, both in the workplace as a union rep and also as a member of the public at large and a mediator in civil harassment court and everything else, the real costs that I think getting people beyond the stigma and access issues, the costs of mental health challenges in the workplace and people being undiagnosed, untreated, unhelped, are huge. And I'm just wondering if you, for employers, for unions, I think those are very compelling things that I don't know how much effort there has been to kind of quantify that kind of aspect of the cost benefit, but certainly seems like something that could certainly help be persuasive when it comes to making the investment in these kinds of approaches.
Yeah, so we definitely know from our data, so from our claims records, we know that people with a depression diagnosis actually have significantly more medical claims cost than people without a depression diagnosis. So that was a big factor in us making that decision. And then I think there's a lot of sort of national data on absenteeism and presenteeism at work with mental health conditions as well.
Thank you. Mr. Slayton.
Thank you, Madam President. Can you disclose the Ginger IO per member per month charge that you have to pay for?
I don't think I can, actually.
Okay. All right, but this is a product design, it seems to be, from looking at the website, structured toward employers. It's not really a retail product out there for people
Yes.
to access. Okay. But it's a negotiated price, I presume. Okay, thank you.
I think one of the things that I heard from all of you is that there's a real need for the primary care physician to be able to help manage and address some of the mental health issues, because they're the first point of contact often, and it can be hard for people with mental illness to follow up and with subsequent referrals, et cetera. And you identified some of the challenges of having primary care physicians who might not be specialists, obviously, in this area, being that first contact or having to address it. But you identified some opportunities where they can be supplemented through telehealth and other things, a consultation. One of the things I didn't quite hear, but maybe it's embedded in what you were talking about, is around case management. Once somebody's identified as having a mental health issue, perhaps it's depression, which can also, in and of itself, the condition can keep you from accessing services because of your lack of interest in daily life and ability to sort of motivate yourself to do whatever needs to be done, and secure the services. But has there been any studies around case management and sort of having somebody do proactive outreach once an issue has been identified with an enrollee?
So what I will say, not particularly case management itself, but I mentioned the care manager in the primary care practice. They are the ones who follow up with that patient, making sure that they get the care that they need, and asking those necessary questions to make sure that they follow through if, in fact, they need more advanced care outside of the primary care setting. So that is a really important role, and that care manager is, like I said, they are a social worker, they could be a psychologist, but they are really equipped to handle any conditions or issues that's associated with mental health conditions.
Yeah, I was just going to say, there is interest in the research literature looking at interventions involving care management. I'm not equipped at the moment to summarize for you the results, but what I do know is that a real challenge is finding interventions like that are cost effective as opposed to effective, because a lot of times you can find something works, but then it turns out to be quite costly. I mentioned earlier the possibility of a cost offset. I sometimes joke that that's a little bit of the holy grail in behavioral health care, that we like to hope that if you provide better behavioral health care that you'll find reduction in costs elsewhere, but sometimes those have proven to be elusive. But I would also argue that we shouldn't expect behavioral health care to pay for itself, as many do. We don't expect patients with cancer to, if you give them cancer treatment, we don't expect somehow to find the savings that covers the cancer treatment elsewhere. But for some reason, we seem to expect that in behavioral health. But I'll just put that out there that, it's really, it's challenging to find something like that turns out to be cost effective, let alone cost neutral.
Okay. Thank you. Did you want to say anything?
I was just going to say, we were recently looking into kind of care navigation with cancer-related treatments. And there is actually a lot of empirical evidence in that area for kind of health advocacy, care management, making an impact. But I would really agree with what Susan says. I think a lot of those initiatives, it's less about saving money and more because it's the right thing to do and it gets people the care they need.
Yeah.
I should also just add, going back to the earlier comment about workplace productivity, I've actually done a little bit of work in that area myself, and there is a big research literature showing the effects of behavioral health problems on workplace productivity. So if you're going to find an offset, it's usually there. The problem is really the incidence of costs, because so often the entity that has to pay for the behavioral health care is not the entity that reaps the rewards down the road of improved behavioral health. Even if it's even if the employer is paying for the health insurance benefits, but people move on, and so somebody may pay today for behavioral health care, and that increases the productivity of this individual over their life course, but a year later they move on to a different employer. And so that's also another challenge that I see a lot, is that you somehow need to match the incidence of the cost of treatments with the benefits of that treatment.
Fair enough. Mr. Miller.
Yeah, and I would say, in my experience, sadly, many times they move on involuntarily.
Well, I'm sure we could continue this conversation for a long time, but we have reached the end of our time for this session.
I have one question.
Oh, I'm sorry, Mr. Rubalcaba. Please,
Sorry.
you go ahead.
No, I'm new on the board, but I do know that we have a very comprehensive plan design. And most of our members, their first interaction, whether they have a medical or a health behavioral issue, is through their primary care physician. And sometimes we have what we call comorbidity. We have two things. You have a mental issue and perhaps aggregated or caused by a physical, medical condition. So I was impressed by the presentation about integrated care. And sometimes the primary care physician will be the first person to see you because because of the stigma and all that, you may want to go to a doctor rather than a psychologist. So I'm not sure if this is a question for Dr. Sun or who, but we have a lot of claims data in our warehouse and all that. Do we ever ask our insurance carriers what kind of integrated care they have? How do they make sure that people are not only treated on the medical illness, but also the behavioral side?
Well, our contracts require our health plans to have integrated care models. Having said that, though, it's difficult to measure the effectiveness of that. The sort of data that we get are claims and administrative data, and for evaluation of an integrated model, you need more transactional and clinical data, and that's difficult. So it's difficult to measure.
I also want to thank the staff putting this stuff together. It's very impressive. Thank you.
Thank you very much, Mr. Rubalcaba. Well, thank you very much to our panel. Let's please give them a round of applause. It's now time for a 15-minute break, so we'll be back at 3:10.